Hi, my name is Ozgur. Thanks for joining us today. Today my topic is robotics and spine surgery. I'm the chief of the Neurosurgical Spine Program at Hoag Hospital, Newport Beach. And we've had various different topics around spine and spine health. Check back at the Hoag YouTube site where there are about a dozen other spine lectures by myself and others as well. And today our topic is robotics. And so there's a lot of interest right now around robotics in the OR and what that means and how is it useful, how is it not useful, is it a waste of time, is it a waste of money, or is it really a good thing to have? The answer is, as robotics evolves, it becomes more useful in the operating room, just like different amenities in our cars, navigation, various things that now we can't live without, like air conditioning and navigation. And so robotics is probably going to be sort of the same thing in the operating room. Right now we do most of our surgery without it, but in general surgery, urology, OB-GYN, there are more indications for robotics, and in spine surgery it's growing as well. So we're lucky here at Hoag in Newport Beach to have the latest and greatest robot for spine surgery. It's the Mazor X, and I'm happy to be the first on the West Coast to have used this robot in spine surgery just a few months ago. And it worked beautifully, and it helped speed up the recovery. Our first patient was actually in and out of the hospital in one day. In under 24 hours he was discharged, and that's after a spinal fusion. So it is a good thing. It's not useful for everything right now, and it doesn't replace the surgeon, but it's a good thing to have, and I'll explain a little bit more now, sort of what it is and how it works. So what this image shows is just sort of the components of this robot. As you can see, it doesn't really look like your idea of a robot in the movies. The little image with the little eyes up top is a camera, and there are multiple cameras in the room where the computer, the robotic arm, can communicate to each other. So at all times we know what's going on, and it's connected. In the middle is a computer, and what that does is that has an image of the spine preoperatively, so before surgery, that we've input into the computer. In this time it's a CT scan. In the future it may be an MRI. And basically it computes what the image of the patient's spine looks like. And then on the right side is a robotic arm that's attached to the operating room, and operating room bed, that is. And what that does is that then controls the arm, for which we program and tell it what to do. So here's an image showing a surgeon basically programming the robot and what we want it to do. In this image, the surgeon is placing an instrument through the robotic arm, and that's going to help us perform the surgery. Now this image is a little complicated, and what it's showing is we've input x-rays and CT scans into the computer, so the robot will have an image of the patient even before the surgery has begun. On this example, on the left side there's a scoliosis that you can see the curvature of the spine. It sort of forms an S shape. And so the plan is going to be to put in instrumentation, which is screws and rods, to try to straighten out and stabilize the spine. And so with the software that goes with the robot, we can actually predetermine where we want the screws to go in, what size the screws are, the length, the angles at which we want to insert, and then try to rotate and correct the spine angle. So it's a lot of stuff that normally we do in the operating room, but the nice amenity to this is that we can actually do all of this before the surgery has even begun. So days or weeks beforehand, we can actually kind of do a pre-rehearsal of the surgery and put the instrumentation in graphically on the computer, decide what looks good and works well and what doesn't, and then modify our plan even before the surgery has begun. The other nice element about that is we can measure the instruments that we're going to put in, so we can have everything pre-available, sterilized, and ready to go in the operating room. So what this image demonstrates is now we're actually drawing in these screws. So there's the spine, and superimposed on top of that spine are the screws and the rods. Here we have screws on one side that are yellow, another side that are blue, and we can basically drag and drop these screws with our fingers, just like as if we're using an iPad, and move the screws a little bit to the left, the right, rotate them until we get them into the perfect spot. So this is all on the computer screen, either before or during the surgery. And so this is a similar image, just showing another dynamic of it, and that is, you see the screws now. They look like typical screws you would use in a hardware store, but we're actually putting them now into the spine. And then again, we can rotate them and just get them perfect, is exactly the way we want in the operating room. Now you can see that this is a video that I'll start, and that's going to show the actual arm. So this is the robotic arm. Doesn't look like a human arm, but it's basically a mechanical arm with multiple axes. And once we engage the robot and we say we're ready to go, then the robotic arm will actually move. Now it has sensors and cameras, like I mentioned before, so it's not going to bump into something, it's not going to push onto the patient. And this robot is in full control by the surgeon. So again, this does not replace the surgeon. This is just an adjunct or an assistant to the surgeon. So it's going to help me do a better job, help me be more accurate, and it's going to help also be more sensitive. So imagine it trying to hold your hand in a certain position for a period of time, as holding a retractor or operating on the human body. Surgeons do a great job of that all the time. But now imagine having a robotic arm that helps us be a little more steady. We all have a basic tremor, some more than others, but if we can work through a robotic arm, that helps us be even more steady and more accurate, because now we're going off of robotic navigation as well. So here, as I play the video, you'll see that the light's flashing, demonstrating that the arm is moving, and it's going to the perfect trajectory that we want to engage the instrumentation, the screw, into the patient's spine. Now this next image you see is the surgeon is standing there. There's the computer screen. There are multiple screens throughout the room, and the robotic arm is there ready to go. And now with the surgeon's control, he's engaging the robot to move the arm, and it's going ahead and moving to the spot that he wants, pre-programmed into the computer. Once it's in that spot, it's going to hold its position, and then there's basically a circular arm that now the surgeon can work through to place various instruments. And so what happens after that point is, once it's holding that position exactly where we want it, it's not going to allow any movement of that. It will even sense if the surgeon is leaning on the robot arm or the retractor a little bit too much. It'll tell you. And so you get it perfectly into that spot that you want it. So why is that important? Well, when we're working on the spine, the spinal cord, the nerves, every millimeter counts. So a millimeter too much to the left, to the right, front, back, deep, superficial can make the difference between curing a spinal problem or creating a new problem. Paralysis, nerve damage, spinal fluid leakage, these things can occur. Thankfully, they rarely occur because surgeons are so well trained and experienced. But even the best of us can use help. And so engaging the latest technologies, such as spinal navigation or robotics, is very helpful. Again, right now we don't use it for everything. Currently it's used for what we call instrumentation. Instrumentation are screws, rods, plates, the metal devices that we put in to help create structure in the spine. That's in the cervical spine, the thoracic spine, the lumbar spine. So it can be used for any of those things. The other way that this is helpful is it's a form of navigation. So navigation is the same concept as what we have in our cars. We'll set a destination where we want to go, and the car will help guide us. The navigation helps guide us in the car to get to that destination. Most cars right now, the driver is still managing and driving the automobile. But in some cars, it's becoming automatic. So if we take that analogy to the operating room, the surgeon is controlling the robot, using navigation. That's we're programming where we want to be, where we want to go in the body for whichever objective that we have. Of course, today we're talking about spine surgery, but you can use navigation for other things as well. Brain tumors, spine surgery, heart, cardiothoracic surgery, and so on. But again, the robot is in full control by the surgeon. The robot is not working autonomously or by itself. Maybe someday, but not anytime soon. But basically, it's, again, a tool that we can use. The surgeon may decide if and when he or she wants to use the robot in spine surgery. So at this time, I can tell you that it's actually been a nice addition to the operating room. We have multiple tools that we use depending on what the objective is. Sometimes we'll engage the robot to help us. Oftentimes we use a navigation with or without the robot to also help us calculate exactly where we want to be. When you use navigation, it allows you to make a much smaller incision, a smaller cut. And that's important because otherwise, if you don't know where you are, you have to make a larger incision, expose more of the spine, more of the body to actually identify where you are, and then use your skills to put in the instrumentation. When you have navigation, when you have robotics, you can keep the incision really small to be able to get the end product, which is putting in the hardware, the instrumentation. So that's a huge plus. The incision size, the reason that's important is not for cosmetics. It's not necessarily that you want such a small scar. But what that means is when you have a small scar that you've made a lot less invasion into the body, cutting the muscles, cutting the bone, retracting the muscles, and creating a space into the body to do the work. When you have a smaller incision, you have less scar, you have less bleeding, you have less risk of infection. Also, what you have is less recovery time. Patients typically get up and walk and move much faster because they have less pain. They leave the hospital sooner as well, so less chance of getting a hospital-acquired infection or other complications. They get home, they get active, and they get mobile faster, which means less chance of infection, pulmonary infections from blood clots in the lungs as well as in the legs because they're getting up and moving faster. So there are a lot of elements down the line that are also benefited from the smaller incisions or these minimally invasive procedures. So overall, the addition of robotics into spine surgery, I welcome it. I think it's a good thing. It's not for everybody. It's not for every type of surgery. It's not for every type of case. But it's one additional tool that we have. And the reason, as a surgeon, it's great to have multiple tools is imagine a handyman with only a screwdriver and didn't have anything else. That's going to be pretty hard to fix things around the house. But when you have a toolbox with many different types of tools, and that allows you to be more effective in your job. And that includes me as a surgeon. I have a big toolbox. I have a lot of tools that I have at the hospital that allow me to be a better surgeon. As we've talked about in previous lectures, what's more important than the procedure is always the diagnosis. So you've heard me harp on this before, but making a diagnosis is the most important part of being a doctor. Because once you work up the patient and you assess the history, do an examination, evaluate any tests like MRIs, CAT scans, CTs, so on, that allows you then to hopefully culminate to a diagnosis. What is the problem? Where is it coming from? Once you've identified and made the diagnosis, then you can decide what is the best way to fix the problem. Hopefully it's without surgery. Hopefully it's with physical therapy, exercise, weight loss, maybe medication, so on. Sometimes that doesn't work and you need to take another step and you use pain management, injections, epidural shots, things like that. If that doesn't work, then sometimes we engage surgery. Do we have to perform surgery, traditional surgery, minimally invasive surgery, and we identify what's the objective. Is it to put in screws and rods and fuse the patient, correct a scoliosis, take out a tumor, remove a herniated disc? And then finally, once I have a game plan, what tools do I need in the operating room to make it more successful? Sometimes robotics and navigation, sometimes not, a microscope, augmented reality. All these things are new upcoming technologies which are exciting and helpful in the operating room for the right case. With that, I think we may have some questions from viewers that we'll take a look, see if we can answer. So one question is that I mentioned it works on scoliosis and fusion surgeries. Does it work with herniated discs? So right now, the most benefit of a robot is the navigation for spinal instrumentation, putting in screws and rods. And that's really to, again, to hold the retractor arm in a certain position so that we may insert the hardware. That can be done freehand with the surgeon's own hand, and we do that all the time. That's the way mostly it's done throughout the world. It's been done for dozens of years. But this is just, again, an additional tool. Now, can you use the robot for like a herniated disc? That's a good question. Technically, you could, but I would say that most of the time you don't really need it. It just probably adds more time and setup, and if it makes it a safer, better operation, then great. But I add the time element because it's better to have a surgery that's efficient, not rushed, but efficiently done with just the right amount of time, not too long, not too short. That's important because you're under anesthesia, general anesthesia. And if you can, you want to be out of anesthesia, the sooner the better. Think of being under anesthesia as being flying in a plane. You want to get to your destination, you want to take off, and you want to land safely. The longer you're in the air, things can happen, good things, bad things, but basically you want as short a flight as possible. Similar in the operating room, you want a short surgery. You don't want to rush it, but you want the job to be done, and you don't want it to be any longer than it needs to be. A herniated disc is done very well and very safely currently without a robot. Maybe it'll come the day when it's going to be better and faster to even do herniated discs with a robot, but currently not. Another question, does this work for anterior and posterior spinal fusion due to kyphosis or lordosis as a teen, and now degenerative disc disease due to age? So that's a great question. First, about anterior-posterior. So anterior is from the front, posterior is from the back, lateral is from the side. The good news is that the robot doesn't care. You can program it to do whatever you want. So with the preoperative imaging, you can plan a surgery from whatever position that you want. The patient can be face down or on their back or on their side. And as long as you can position the robotic arm, the cameras, the computer, and get it all lined up properly, you can do the surgery from a front or a back or a side or an angled position, any position that can be done. So that's the great thing. Can you use it to help in correcting kyphosis, lordosis, scoliosis? Absolutely. It can be done. Again, it just depends on first making a plan, surgical plan on how to correct the problem with or without the robot. You just need a plan. And then secondly, for the surgeon that you've asked to do the surgery, what are his or her experience points, tools that they need to have the best outcome? Currently, because the robotics is pretty new, a lot of people don't have a lot of experience with a robot. And so some surgeons may use it and most surgeons won't use it. What you want is the best experience to fix your spine problem. And that's where, as I've said in prior lectures, get multiple opinions. Don't be in a rush if you have time. See multiple surgeons and see what their approach is to fix the problem. Another question is, can the doctor change his mind and intervene the robot? What if the patient moves? Great questions. So patient moving is always a concern whether you use a robot or not. And that's why general anesthesia is used for most of spine surgery. General is when you're fully asleep, there's a breathing tube down, and you're on a ventilator, and the anesthesiologist can then give you various medicines, including paralytics, which means medicine that paralyzes the muscles during the surgery so the patient doesn't move. So sometimes we need to use that, paralytics under general anesthesia. So in that case, the patient won't move. Now, if the patient gets light on anesthesia, then they can suddenly start moving. So that obviously is a problem. There are sensors in the robotic arm on the table and around to detect if the patient's starting to move, and the anesthesiologist can detect that as well. So yeah, it's not a good thing if the patient is moving during spine surgery, and we do everything we can to minimize that. And it's a fine balance between having the right anesthesia, the medications, not being too deep, not being too light, but just the right amount. And then as far as the doctor changing their mind, absolutely. You can start the case with the robot and then decide, I don't need it, or I don't trust it, or something has changed. That's why you always want the physician to be there, controlling, being basically the commander of the ship during the surgery. They decide what is the best equipment that they need to accomplish the task and what tools they need, including the robot, and then they can change the plan. So intraoperatively, let's say something moves and I think that the robot is inaccurate, which can happen. Something has moved, the cameras are not detecting things properly, there's a malfunction. The surgeon may make a decision where he or she at the moment says, listen, I don't believe that the robot is accurate at this time. That can happen, and that's happened with earlier generations of robots where they would come out, we would test them in the lab, for example, before bringing them to the operating room. And there's a certain level of failure that we, of course, don't accept in the operating room. And so if that happens a lot, we don't use it. So this is not the very first robot that's come out. There have been earlier robots that we felt were not safe, and we didn't bring it here to Hoag, and I didn't allow it in my operating room, for example. But until it's gotten to the point where there are published articles on accuracy, success, safety, other surgeons that we know that are starting to use it, have used it, and then testing it in the labs and practice cases, when we have that trust level, then we bring it into the operating room and we use it, just like any other new equipment. Another question is, when you use robotics, does that reduce the amount of surgery time? Great question. Sometimes yes, sometimes no. And the reason the answer varies is because if you're using it for a surgery that's otherwise really big surgery, and you're making it less invasive, smaller cuts, and you're using the robot, yes, it could dramatically speed up your surgery. On the other hand, if you're using it for an indication where we normally don't need it, for example, a herniated disc, the earlier question, a herniated disc surgery may take 45 minutes to an hour, hour and 15 minutes. It could be a quick surgery. But if we end up setting up the robot, which takes time, calibrating it, checking it, and then using it, that's going to add much more time. So a herniated disc, for example, will become a much longer surgery, and that's why I say we don't really need it currently for that type of surgery. But a bigger case where we're putting a lot of instrumentation, screws, rods, so on, the setup time will add time, but then the save time from how much faster we can do the surgery safer, less radiation, less x-rays, because we've got the robot, then in the big picture, it's actually a shorter surgery. That's why it's up to the surgeon to really kind of figure out when is it good to use and not use. It comes back down to the experience level of the surgeon. Another question comes in, would you use this for a laminotomy? So a laminotomy is basically removal of part of the spine. Lamina is the back portion that forms the spinal canal. Spinal canal sort of looks like a circle or a triangle, and then the TP part, top part, is formed by the lamina. Those are sort of the walls of the back of our spine. And if you remove part of the lamina, that's called a laminotomy. So we do that sometimes to do a decompression. When the spinal canal is really narrow and pinching, we can remove part of the lamina to make more space for the nerves, or to gain access into the canal to remove a piece of disc, for example, for a discectomy. So that's laminotomy. Can you use it for, can you use the robot for a laminotomy? The answer is yes, you could. But at this point I wouldn't either, just like I wouldn't use it for a discectomy, because a laminotomy is typically a quick, very reliable type of surgery that every surgeon can do, every spine surgeon can do, and the robot doesn't add much for that currently. Now again, in 5-10 years that may change, and it may be something that we're incorporating a better version of a robot or some enhancement to our hands. Maybe we're wearing something on our gloves. That may all change, and I wouldn't be surprised at the rate of technology currently. But currently I wouldn't use it for a laminotomy because I don't think it adds much. So with that, I want to thank you for your time and your attention. It's been my pleasure each time to be with you talking about different spine indications, diagnoses, treatment options, minimally invasive surgery, and today for robotics. Again, feel free to go back to the Hoag site on YouTube to see other lectures that we've performed, and give us suggestions. Write in and tell us what else you want us to talk about, and we'll continue providing these programs. Thank you. Have a good evening.